It's just great to be here. This is a wonderful opportunity to hear from a number of women and to really leave the day being inspired. And I've already got sort of dose one of inspiration this morning from Robin. As Dave said, my name is Karen Amstutz. I'm the Chief Medical Officer for Magellan Healthcare, and I'm a physician with training in internal medicine and pediatrics. I've had a 25-year career at the intersection, really, of medicine, reimbursement, as well as clinical practice and analytics. Through roles I've had being a practicing physician, being the medical director of a large medical practice that actually had an early electronic medical record. So as far ago as like 20 years, we were measuring ourselves against clinical guidelines and putting in place improvement strategies, as well as now over 10 years being a physician executive. I'm also the daughter of a computer scientist, and it's not what you're thinking, actually. It was my mother that's a computer scientist. She studied math in the 1950s, then had my brother and I, and after we went back to, or actually almost finished college, she went back to school and had to get another bachelor's degree and master's degree in computer science because the field had progressed so far in really 20 years, and then had a 20-year career in the workforce. So she is really, I think, an inspiration when you think about someone. She's now 80, living in a continuing care community, and a bane of existence to the network administrators because she finds all the little glitches. In fact, there's a great story there. Since you're laughing, I'll share it with you. So just after she and my my father moved into this, and they're living in Seattle. It's a continuing care community, and you might imagine there's a few Boeing engineers there. And everybody's getting a little irritable because they keep getting kicked off the Wi-Fi and nobody can figure out why. So she assembles a posse of about 20 or so of these folks, and they all descend on the main building, so with their devices, so they can sign on all at the same time and create the signature that they need to diagnose what was indeed going on. And indeed, there were login failures that were taking place because of device interactions, but not exactly what the administration was expecting from this 80-year-old lady. Apologies here. There we go. Just a little shout out to Magellan. We'll conclude with this. But I really want to start talking about kind of a moment 30 years ago when I was working nights moonlightings in an emergency room. So when you're training, once you get done with your internship, you're really allowed to go work, and of course you get all the things that no one wants to do once they get to be in real clinical practice. But I vividly remember this moment because I almost misdiagnosed somebody because I was missing medical information. So this 44-year-old lady walked in. I mean, I remember her age. I remember what she looked like. It was one of those sentinel moments. She was tall. She was slender. She had long blonde hair. And she just presented looking really sick and saying that she felt sick to her stomach and was vomiting. And that was it. I ordered all the typical tests you would do. Her exam was really unremarkable except for a scar on her abdomen, and she couldn't remember what procedure she'd had. All her medical testing came back normal. So I began to scour the medical records I could find. And at that time, there were 4 inches of manila foldered medical records, all with 2 little holes and clipped together. And there was nothing in there that was helpful. I called her physician and spoke to the on-call coverage who didn't know this patient. There was no medical records departments open at the facility where she said she had her procedure. And since by that time it's 3 in the morning, I thought I'll just keep her until the morning. She looked so sick, she didn't have family, and we'll see when her physician arrives. At 7 a.m., her physician arrives to do morning rounds. He promptly relays her history, including naming the abdominal procedure. And it was now obvious that the test she needed was an EKG because she was at high risk for a heart attack. This close, right, to misdiagnosis without this crucial piece of information. And today that probably wouldn't happen, although it still could happen. We have largely, installed electronic medical records into hospitals. Much of that information is more searchable, it's retrievable, it's even readable now. However, if that hospital doesn't have the ability to interface with other hospitals, we still would not have had that information. So, for example, you're now creating health information exchanges or even networks for patient care like we have in Indianapolis, which aggregate all the data within a county and city and present that data in a chronologic fashion to treating providers to prevent errors of this type. So the last century has seen a lot of tremendous progress in technologies that have impacted health, but data, information, and decision making have largely really stayed in the hands of the treating provider. And what's changing today is the expansion of data about people, data that can be used to create metrics and measure better health, and data which we believe can help both providers, but now extend into helping all of us as patients and people pursue the health that we need to pursue. So data which will be analyzed and tools and approaches that are commonplace in other industries are going to be translated into healthcare. And we're at that inflection point. And irregardless of whether you have a career in healthcare or not, this change will impact you personally, if not professionally. So healthcare delivery really is the next major U.S. sector that's going to be disrupted by technology, data, and analytics. And analyzing health data is really being driven by this need to produce a better product, better outcomes at a lower price, and with equitable distribution, which we call access in the healthcare rule. When you think about health outcomes, they're really a function of a couple of things. They're a function of healthcare service delivery, and they're also a function of the biopsychosocial environment in which we all live. And both of these health data domains are really important to doing person-first analytics. And I think we all want person-first analytics. We want the data analyzed at the individual level for us. We want treatment guidance and we want very personalized treatment guidance given to our providers or to ourselves with options. We want to move to that place where we're actually pursuing the options and making those decisions in partnership with a provider. And I want to discuss both of these domains. Some of the most complete healthcare data today exists from the healthcare service delivery process and reimbursement. So the foundational healthcare services data sets include the healthcare information from payment for health services, which we call medical and pharmacy claims. The word claim comes from the insurance industry use of that convention, but it really is an electronic copy of the bill for reimbursement along with a number of data fields that are added as the claim is paid. Pharmacy and medical claims are actually have different formats and are usually referred to as different data sets. Payers actually also accumulate a lot of data about each provider, including their service locations, their specialties, and their billing practice. And this becomes really important in terms of catching fraud, waste, and abuse, because if you have a pediatrician billing for a cardiac procedure, you can instantly know that probably is not a valid claim. Information in electronic medical records called EMR or HER, in which it really encompasses everything from the patient visits, the labs, the radiology imaging, op reports, and it tries to organize that information in meaningful ways to the user. And this is really an area of a lot of intense work. Because right now, if you talk to most providers, they're going to tell you that the EMRs made their lives worse, not better, because it wasn't designed from the perspective of the clinician user, and it wasn't designed to fit clinical workflows. It was designed to fit other workflows. From a data science perspective, the configuration has additional challenges, which I'll touch on later, but I think all of you know it was configured with many, many text fields, and so natural language processing and other dictionary like functionality is necessary in order to actually access this data. So the next set of data that's really important, and the next domain is really this biopsychosocial domain. And that's an area that's just dramatically increasing, as the ways that we collect data on sort of the human experience expands. So we're digitizing this environment in such a way that it's going to lead to some probably really profound insights into what determines health. In fact, if you look at healthcare spending in the U.S., we look like an outlier compared to other developed countries. If you then say, let's add healthcare expenditures with social expenditures, and you plot the U.S. against all other countries who are developed countries, we'll be right in the middle. So our balance of healthcare and psychosocial or social spending is not quite there, and I think we're going to actually discover that as we have data sets with more insights. The data that the way we're sort of digitizing the human experience and creating these huge stores of data is really from all of our devices. So we're creating digital signatures of ourselves when we use Facebook, Instagram, Twitter, from wearables such as our Apple Watches and Fitbits. And they're capturing, every word we write, every footprint, every heartbeat. And so imagine how much data there's going to be. You imagine that, all of this data from our digital footprint. Imagine if you take that with your genome that's been sequenced, with all the electronic health record data that sits on the medical services side, how much data that there will be. And digitizing this, this human experience is really leading to what I call these sort of gigasets of data that are going to be integral, impactful, and relevant to maintaining health and extending really our lives. So what's happening here, from the supply of healthcare perspective, is the fact that we're combining data sets and driving this need for new sophistication in analytics. And if you look at the traditional hospital IT shop, hospital or healthcare, and I can speak on behalf of our company, we're going through major transitions in terms of how what our functionality is, where our skill sets need to be. And healthcare is just transferring and adopting these techniques from other businesses and creating careers that didn't previously exist in companies which didn't previously exist. So it's very, very exciting. But if you're coming from outside of the healthcare field, there's a few things that you're going to want to know, and some of them are about the data sets as you transition in and sell yourself. Right. So one of the major focus areas that I'm really have a lot of expertise in is really the health plan and managed care businesses. And in those businesses, the information, that business actually is built on measuring quality. And we are selling our products, particularly in the government product space. We're delivering sort of some services. We have, but our product really is becoming the quality of our provider network. And we're judged on that. I think if you know the Medicare Advantage program, we're judged using something called Medicare Stars. In the Medicaid program, state by state, we're given quality metrics. And we're not talking about 6 or 7 quality metrics. We're talking about nearly 100 typically that we're being judged. So we're really beginning to think of our products as we're producing quality outcomes. One of the places that almost every organization that has to intersect with this provider payer world learns about is a methodology called HEDIS. HEDIS stands for the healthcare. It originally was the Healthcare Employer Data and Information Set, original word. But it's created by the health plan using some very rigid criteria set by NCQA, and primarily originally based on the transactional claims data sets, now augmented by any kind of data that we can pull in that we think will be helpful. So that includes data from state immunization registries, lab testing values, electronic health records, and when necessary, we even have to go back to the paper medical review. The report measures outcomes across many domains, including access to care, use of services, quality, and clinical outcomes. But where this gets actually really fun, is not actually the report creation, which is a very rigid report. It's really when you're starting to say, hey, we are measuring care delivery and gaps at the individual member level. We can actually use our data set in combination with other psychosocial data sets, and we can begin to understand and identify gaps in care for the member, and even more important, identify those members who have, for example, diabetes, have not gotten needed care, and potentially identify the most appropriate way to message and nudge that member into a behavioral change and to seek needed care. This information can also be sent to the provider to empower him or her to take action and schedule a visit. So there are many uses, and we use this in aggregate now. We use some of these measures in aggregate as the basis for the value-based payment strategies that are being implemented. And while I'm not going to spend a lot of time on there, that's probably an entire discussion all in itself. The validity of the data and the measurements that you create when you are having that discussion with providers are absolutely critical. And missing data is the biggest way for any of us on the health plan side who are discussing data and measurement, particularly related to the quality of clinical care. It's the biggest way that we lose credibility. So our next challenge organizationally really is to create much more sort of sophisticated forecasting tools and some prescriptive analytics. We want to really be able to tell sort of not just our provider community what folks need, but our internal health plan group what we think is the best way to interact with the member. What's the next best step for them to take? What goals should they take? And we've actually also used sort of some really sophisticated analytics to understand our patient population and learn things that were not intuitive to us at the time. So there's still a lot of work to be done on to solve the data accessibility outside of the organizational boundaries, and I think this is one of the biggest challenges that we face within a healthcare payer in the healthcare payer and managed care space. There's a lot of opportunities. Actually, it's not just an IT issue. There are also opportunities in this space for non-data scientists, because there's such a huge regulatory and policy component. And a huge amount of what we do as we think about how we interact with data sets is to understand what are the data rights that we have. In healthcare, every data element almost comes with a set of data rights governed by how you acquired that data. And you've got to be able to follow that through with as much precision as you can, the actual numeric calculations that you're performing. So healthcare professionals are becoming business entrepreneurs. One of the probably biggest areas they have to have a sixth sense in is to be aware of the regulatory environment. And they're beginning as either entrepreneurs or in many cases intrapreneurs are leveraging skill sets from other business applications. And I think that's a really key point to consider as you're considering as leaders. For example, within Magellan, one of the things that we've done is extensively hired from outside healthcare in order to support the transformations which we are making in our business. Srina Kuchek, who's our CTO, has extensively hired from outside healthcare because we needed folks with experience in things like data lake, supply chain of data that we could not get those skills. They're just not accessible in the marketplace with healthcare background. We have actually also used a similar approach in our data science environment. And Abaya Knight, who's my VP of Advanced Clinical Analytics, recently hired an individual from a government agency who had a lot of expertise measuring from surveys. So outside healthcare coming in, but with a huge amount of expertise on the consumer, measuring in the consumer experience. From an electronic medical record perspective, I think and I alluded to this, they was really initially configured with these text fields. And within those text fields are a lot of acronyms which require context. So the natural language processing sophistication that's going to take to actually use some of the data that's stuck within electronic medical records is going to be pretty profound. We're additionally seeing the need because there's so much of a signal to noise problem, we're seeing the need to provide clinical decision support as well. So using that data and really giving the clinician something exactly what they need. It may even be saying, hey, the next best step for you is this radiology test, and for these reasons, is this one you want to do, yes or no? There's within the EHR world, there's one other example that I want to relate to you from Geisinger Health System, which is a health system just east of here in central Pennsylvania. And they actually are one of the early innovators in combining health plan data, health system data, and health information exchange, or HIE data, into one data set. And every night they actually make a duplicate copy of all the data they have available and put it in an environment for analytics that are jointly designed between data scientists and the physician leadership. So they're looking at all aspects of clinical practice. They're creating the insights that are going to drive the orders that are going to be put into the system the next day. And they also do aggregate projects where they look at sort of the overall population-based treatment of things. One of the conditions they looked at was chronic obstructive pulmonary disease, or COPD. And the reason they looked at it is the guidelines came out and said, look, if you want to say someone has this disease, they need to have a pulmonary function test. And when they indeed looked at their population, less than half or fewer than half of the patients who were diagnosed with COPD had actually had a PFT. So they've got this, slick way of inserting the orders. They insert the order set in with automatic orders. Physicians can say, hey, they can opt out, but they're used to it. They have a governance process for putting in these automated orders. And so as patients began to interact with the healthcare system, pulmonary function tests were ordered and completed. 3 to 6 months later, when they analyzed the data, what they found from the results of those pulmonary function tests is half the people did not have COPD. Think about that. Half of the people who were originally diagnosed with COPD did not have COPD when you did lung disease. They had restrictive lung disease, not obstructive lung disease, which has profound implications for how you're going to treat. And it really is a good reminder that getting that diagnosis right is critically important, and there's going to be a huge role that artificial intelligence, machine learning, and other techniques play in this partnership between data science and clinical practice. So the last area I want to touch on is one you probably haven't thought much about, and that is that software is actually becoming therapy. So software is becoming a therapeutic modality, and in some instances it's as effective as a molecule, so a clinical, a chemical molecule that we call a pharmacy product. So this is really synonymous with the revolution that came from sort of the single molecule drugs. And the first place that we're seeing it is in sort of digital applications for therapy and behavioral health. And this is, Magellan has historic roots in behavioral health, so it's a natural fit for us. For over 20 years, the National Health Service in the UK and in New Zealand has been using desktop technology, so really kind of crappy interfaces, and trained computers to do psychotherapy using a very specific technique called cognitive behavioral therapy. And it turns out that CBT is as good as the best therapist and better than most therapists. It's been studied for conditions like insomnia, depression, anxiety. It is as effective as medication as a first-line treatment in depression, anxiety, and is the preferred treatment in insomnia. So even even more amazing is when you stop a medication for depression, the impact goes away. When you've treated with CBT, the treatment is actually continues to have an impact. You've learned new skills that apply. So it's actually even more effective than treating with a medication. And it has no side effects. Very well studied, lots of published literature, but as you start to think about the roles that you could play, there's these increasing roles in impacting how patients are treated, not just in the, do I have the right diagnosis and what's the next step, but in this actual realm of therapy. As another example, we actually have a product that is in partnership with a company called Click Therapeutics. Click Therapeutics is one of the early digital therapeutics companies. Again, these are companies that are combining, either have pure software treatment products or they have software combined with a medication. And in this case, we've combined a medication with software for smoking cessation. The patients interact through an app, but what's more interesting from your perspective is behind the scenes, they've taken sophisticated analytics, predictive analytics that are used by the investment community to try to figure out when is the right time of day to collect information from someone. What is the right time of day to get you to interact with this app so that we can actually have the biggest impact on your ability to quit smoking. And we have phenomenal results in terms of the percentage of people that quit smoking for at least 6 months. Far exceeds using nicotine replacement alone, and we also can get 80% of people that interact with the application at least once a day for 3 months running. So it's incredibly effective because the app knows when it should interact with you. Pretty cool, and I think it's going to be a cool, if you think about the analytics, it's going to be we're starting to think about, what are the other ways that we can combine a therapy with analytics. So just returning to back to my original 44-year-old woman, how would her experience be different today in a healthcare system powered by analytics? So first of all, the healthcare electronic medical record would include her health information. We would hope that we're living in a world with interoperability. Healthcare organizations like Magellan or provider groups would capture and share information, as would patients share their social profiles with organizations. ensuring that critical information on medical conditions and social conditions, such as in this case, the condition that led to this patient's heart disease. Population analytics would classify her risk and would ensure that she doesn't follow up, that she ensures a follow-up for visits. They would classify her as a higher risk patient. She would get a different intensity of services, and hopefully those services would be proactive because we would know what she needs before she knows herself. And finally, if we needed to help her quit smoking, digital therapeutics would assist in quitting smoking or in complying with heart disease medications. And all of this is really going to be made possible by people like you, working in partnership with people like me, and creating new products. So thank you. I'm going to turn on the microphone, and if you guys have questions, would love to take some from the audience.
I have a question.
Sure.
For the use of CBT, what does billing look like for that?
So the question is, what does the billing look like with CBT? So CBT right now is going through right now we sell it. It is not a billable service in most locations. It can be billed or it can be treated as a bundled service, but it does not have a CPT code. I think New Jersey Medicaid might be the exception. What we are in the process of doing is these digital products. The FDA actually recently, in August of 2017, is started sort of a pilot program to actually look at and certify digital therapy. So I think they're trying to figure out how to regulate the industry. It's clear, as you know, you go on the App Store, there's 150,000 health apps. It's not clear which ones are really therapeutic and which ones aren't. Once things go through an FDA process is really when we think they'll probably get a CPT code. Having said that, there are other settings, and we've got CBT, digital screening for behavioral health conditions. One of the most important things in treating behavioral health is actually the screening, and so you can get people into therapy. Half the people admitted to a hospital with fulminant behavioral health symptoms have not been seen by a behavioral health provider. So you've got really this crisis of, in no other disease do we have, except for potentially addiction, do we have such bad outcomes in terms of people who are presenting so sick they're in the hospital and that's their original presentation of the disease. So there's a huge need to improve care and primary care, and in fact we work with a lot of large integrated delivery systems. So physicians practices who are taking risk for populations are increasingly installing the screening in CBT because it's a way to increase access. We also have the tools available in English and Spanish, and we're close technologically to have it in a form that would allow us to add other languages very easily. So the physicians are actually adopting it and promoting it in those situations where they're being paid in capitation or some kind of shared savings arrangement.
I have a question. So,
Do you want to come up to that would be...
I'm really loud. I'll bring it to you. It's okay, I'm really loud. So I was just wondering what your opinion is on using blockchain to store electronic health records.
So the question is is about using blockchains to store electronic medical records. That's really from outside of my area of expertise. I think the company I work with spends a lot of time, as I'm sure a lot of you do, thinking about the security of data, and I really just don't have the expertise to be able to comment. It's certainly getting a lot of attention right now, and I'm reading a lot. And I think when we think about it from an organizational environment, it would just have to pass all of the other. There's a whole number of steps that we go through for security clearance, and I think the technology, at least probably from our company's perspective, is probably too new for us to even know what to check. But it's certainly a very appealing strategy.
My question was regarding data security. We're collecting all this data. Are there any regulations how to secure the data, how it could be processed, especially within the healthcare industry?
So the question is really about securing the data and the regulatory environment. So I'll take those as two separate questions. The data security piece is actually something that everybody who exchanges data in healthcare takes really they just treat it very carefully. We have sort of set protocols that we go through, and there's actually even regulations that say, hey, you've got to pass these kinds of tests in order to actually, and then you can get a certification, then your company can be certified to be data exchanging with a certain level of security. So there's a lot of regulatory regulation around the actual data exchange process. On the data itself, that's an area that we actually pay a huge amount of attention to. We have some state Medicaid agencies that say, yes, you may be doing services for us, but we own all the data that you create as that process. And you can't do anything with that data without getting permission from us. We even have one state that won't even allow us to exchange data with providers unless we have a signed form from the patient. And so you can, for certain conditions related to behavioral health, and so you can imagine that we actually, when we're exchanging data with the providers now, are exchanging incomplete data sets because of, and this is in particular a federal law that prohibits behavioral health. So you almost have to think about your security and your regulatory environment. It's actually part of the data element itself. So as you're storing the data, that data has to be tagged with how did that data get created and what set of regulatory rules actually are governing that data, so that if you don't store it like that, it gets very difficult to go back and figure out, especially years back, where did this piece of data come from, and am I really legally allowed to use it? So we're really beginning to think about sort of that combination of integrating the regulatory environment into the data storage environment so that we've got things tagged. I think the way we used to do it was segregating it. As we aggregate our data in data lakes, that's when sort of addressing that issue becomes much more important.
So how much of that, on the same lines, how much of that data aggregation is going to be, in your opinion, be prohibitive because of the basically different goals of a payer and a provider? The payer and the provider have exactly opposite goals, right, when it comes to claims. I want to pay less and I want to get more, kind of. So from a commercialization standpoint, in addition to all of the data security issues and all the regulations, how do you think they are going to collaborate?
So that's a great question. How are providers and payers going to collaborate? I think increasingly the way the collaborations are taking place, and they're very complicated, are being driven by value-based payment arrangements. So you're setting up arrangements where the providers are getting paid to do a different set of things. So not just complete a claim and submit it for payment, but potentially also meet other targets. And those targets could be utilization targets. Usually organizations will have a quality bar. You have to meet a certain level of quality. So you've got to align the incentives between the payer and provider in order to get that to work. And they're very complicated, very complicated arrangements to negotiate. They're very complicated arrangements to put in place. And I think, from our perspective, as well as from other people I've talked to in the industry, I think we're really at the infancy of getting those to work. Having said that, I think we all have the incentive to actually merge our data sets in such a way, or at least the relevant data of data sets, in such a way that we actually are providing patients with the right care. Because getting waste out of the system is really how providers do a better job. That's how they're going to make their money in the new value-based world, and that's how the government, who's increasingly put a lot of pressure on providers, is going to make some of the transformation happen in terms of waste reduction. I think folks think about a third of the reimbursement right now is probably claimable in some other format because it's actually considered to be waste.
You spoke about how EMRs aren't designed for physician use and that workflow can be problematic. Some of the pushback I've gotten, or I've been privy to, is that physicians don't want extra steps in that workflow. So I wondered if you had any opinions around where to put data-driven insights on healthcare into the EMR so that physicians can implement that within their workflow and advance their patients' healthcare.
So I think this is actually where analytics is going to become really important because I think I think there's some workflow analytics that probably have to be done to actually eliminate the steps and that can be done by other people. I think it's really important to make sure everybody's doing work at the top of the license, and any work that can be done by somebody besides the physician is done by the non-physician. And the other piece is it's always at the point, you need them the minute that you need them when you need them. So if we know that you're going to be ordering a radiology test, that should be what pops up right then. So it's got to be point of care, and this has actually been pretty well studied for 30 years or so in terms of if you serve up, you can change physician behavior easily by serving up the right information at the right time. And if they've got what they need there, they'll make the decision that everybody knows is the standard of care. If they have to look for stuff too hard, then they'll do something they'll do whatever is sort of the most obvious thing in a data poor environment. So even thinking about somebody is ordering a new CBC panel or a SMAC 12, and you say, do you realize they just had it drawn on the ER 3 days ago at a different facility? Boom, you can prevent the ordering. So that's been fairly well studied, and I think it's going to have to be right at the point of care with as few clicks. It's possible that we may end up with sort of new interfaces that are specialty driven. Because what the view that I might need is when I'm a pediatrician is going to be different than the view that I need as an internist. And certainly if you're a urologist, you're going to want a completely different view, for example. So, more questions? I think we're probably just about out of time. One last question.
In an environment where it's a reality that with limited resources, you've got a variety of patients, and often I would imagine the cases that some of the most complex, highest risk may also be some of the hardest to impact. So my question is, in an environment where it's not ethical to randomly assign folks to get an intervention and not, right? To know which ones will have the greatest ability to be influenced. How do you prioritize your focus?
So I think, the answer is about, you've got the patients who are sometimes hardest to impact are the ones that are the most complex. And what I would say is that I think the prevailing sentiment in the industry is that we really have to design new care delivery models for that group. And if we design the right care delivery models, we're going to get substantially different outcomes. From an ethical perspective, there's so much data. When we're designing something like that, and in fact, we have a pilot for one of our Virginia plans that's doing putting in an advanced illness care model. We have enough historical data that we can use historical data as a control and just match folks. So we'll do that. There are large data sets. If you're working in Medicare or Medicaid, there are large historic data sets that you can choose. So if you need to find a comparable population, and you can do that. And in fact, if you work for an organization that has enough resources, there are data sets that you can purchase from companies that will give you a national representative data set that's across commercial, exchange, Medicaid, Medicare, and again, all de-identified. So those of you who are insured by that company, your data is going out there, but it's actually being resold for use in comparative purposes. So there are data sets, and again, when you're working with vulnerable populations, it's typically going to be Medicaid, Medicare, and those data sets are available from CMS. And that's actually how we do it. The other thing is a lot of times there's ramp up time. So, I may have a population of 100 people. I'll start a program and only be able to touch, 10. So it just, sheer logistics will also give you sort of sometimes a time delay comparison group as well. All right. I think that was our last question. Thank you all for your attention and for coming today.